Yes, so how will they give the numbers? You keep this thing in your mind. Okay, I think next time we'll perform much better. Thank you very much. Now we start. Is it ready? We start the session of Dr. Uday Kokar.
Good morning, everyone. It's wonderful to talk to you about a topic that is close to my heart, that is diagnosis of facial hyperpigmentation with the help of clinical histopathology and dermoscopic correlation. At the outset, I would like to thank the organizers for inviting me for this wonderful conference. I saw the reviews, it's great, and I'm happy to be here with you talking about this condition. So we begin with the beginning, the most common of them, melasma, and we all find it very easy to clinically diagnose melasma. But that's what histopathology, that's what the dermoscopy starts looking in its early phases when you see small granular pigmentation appearing around the follicles, accentuating the reticuloglobular pattern initially in a patchy pattern that tends to coalesce, forming the individual freckle of melasma. And later on, it tries to encircle the globules, which are represented by the follicles. Actually, that's gives rise to the curvilinear pigmentation around them, and eventually the jelly signs. This is a little bit more advanced melasma where you can see little bit Fitzpatrick type macules occurring because of hydroquinone pigmentation. This is a histopathology of epidermal melasma, where the pigmentation is more or less exclusively epidermal. You do see a bit of infiltrate because biopsies in melasma are rarely done in early cases. Most of the times they are done in late cases when it doesn't respond well to treatment. And this is the usual melasma where you have a mixed dermal and epidermal picture. And that's what mixed melasma would look like, where areas of brown pigmentation are mixed with a little bit of darker pigmentation, and larger globules start appearing in the, you can see some larger globules starting to appear because of coalescence of pigment granules, the larger globules that you see here, and encircling of the follicles gives rise to jelly sign. I think it's best seen better later on. Use of steroid creams gives rise to this telangiectasia, so abuse of steroid cream rather gives rise to this telangiectasia in melasma. And this is the so-called jelly sign, where of course you can appreciate the darker nature of pigment over here, indicating it's mixed melasma that has been present over longer duration, and that's the so-called jelly sign. In ochronosis, darker pigmentation takes over, which is grayish in color, and at times slightly elevated areas as well as these lighter Fitzpatrick macules are interspersed among the pigmentation. And histopathology shows this so-called banana bodies, the ochre or yellowish brown pigmentation of the collagen that you see over here, typical banana bodies. And on dermoscopy, you have these curvilinear or linear specks, lines which are typical of ochronosis, and these Fitzpatrick macules are represented by areas of hypopigmentation. There's also a bit of reddening because of erythema at places, because these patients commonly use combination creams. In lichen planus pigmentosus, it begins in these areas, but if you get a patient with such early lichen planus pigmentosus, you might call yourself unlucky, because this patient is liable to progress most of the times, and the patient, it's very difficult to hold such patients because in spite of trying immunosuppressants, they tend to progress. So it's easier to diagnose and hold this more advanced pigmentation cases where the pigmentation tends to coalesce or is diffuse to start with, and at times it does involve the whole face and commonly extends also to the neck and upper trunk. On the neck, particularly, we are able to see this very follicular pattern, and on histopathology, we see an infiltrate around the upper plexus of lymphocytes predominantly with melanophages that are scattered. And on closer examination, you can appreciate that there are colloid bodies at the dermoepidermal junction or macular change sometimes on the infiltration by lymphocytes, depending on the stage of inflammation. In lichen planus pigmentosus, the pigmentation that you see on dermoscopy is in a little bit of darker gray or bluish pigmentation, but sometimes it can be brown as well. But many times the typical pigmentation is dark gray to black or bluish, and it's present in granular or globoid pattern, and it tends to follow appendages, giving rise to this M-like pattern. You can see double line of granules parallel to each other over here, as well as over here. That's the typical pattern of, and a similar condition that affects the trunk more often is erythema dyschromicum perstans, which affects the trunk and the extremities more often, and later can affect the face. You may see a fine degree of erythema in these cases. And on histopathology, which is similar to lichen planus pigmentosus, you also see epidermal hyperplasia. You can see a bit of infiltration of lymphocytes at the dermoepidermal junction. And the dermoscopic pattern of acidomatosis is, though similar to lichen planus pigmentosus, it tends to be darker in color with finer granules, and that tend to coalesce, and if you compare it with a bunch of rhododendrons in black and white, gives rise to this rhododendrons pattern on a dark background. So it's particularly seen better towards the periphery of the patch. And occasionally we see cases where they resemble freckles, but they are not present in photo-distributed pattern. Of course, these are the DPN or the dermatosis papulosa nigra lesions. I'm not talking about them. I'm talking about these fainter brown macules. And unless you examine the axilla of this patient or the covered parts, you may not get a clue to diagnosis. And of course, when you see this, it becomes obvious that it is Dowling-Dacos disease, the histopathology of which is absolutely classic. In addition, you may get comedones in addition to the pigmentation and the delicate proliferation of the rete, branched proliferation of the rete, so-called antlight. And the histopathology is typical, but the dermoscopy is, I would say, even more fascinating with its polyangulated macules of accentuated reticular pigmentation that are typical in this condition. So really fascinating to look at the pictures of this. Acanthosis nigricans, a more vexing and more common problem in these days in youngsters, where you see early acanthosis nigricans commonly affects the forehead, and when it affects the forehead, we frequently label this as frictional melanosis when it is seen only on the forehead, but actually it's early acanthosis nigricans. When it is affecting the rest of the face, it becomes more easy to diagnose, though, And histopathology is characteristic where you see not just slight papillomatosis, but also basket weave orthohyperkeratosis that includes the affection of the infundibula and the acrosyringia. Dermoscopic patterns are also quite typical, the linear criste cutis pattern and the sulcus cutis pattern, which early on are difficult to identify, but once you get used to them, they become easy to identify. You see particularly around these white globules where you can see curvilinear pattern around them, and on higher power it becomes more obvious. This is more advanced case where you have this criste cutis and the sulcus cutis curvilinear pattern. The little lower power of the same, but on higher power it becomes more obvious, very easy to diagnose acanthosis nigricans on dermoscopy. It's an important test to do for undiagnosed pigmentation, diffuse pigmentation of the face. So it's very easy to do. You need not do a biopsy. Of course, biopsy does confirm it, but it's an important thing to do. Post-inflammatory hyperpigmentation comes in various forms and various patterns, but the dermoscopy and histopathology remain similar. So important to do these tests to confirm if one is not sure. This is of course transverse nasal groove in this patient. That's a different condition. This is histopathology of post-inflammatory hyperpigmentation, where you have melanophages in small number in addition to perivascular infiltrate and a bit of infiltration of the epidermis with hyperplasia. So in dermoscopy, in post-inflammatory hyperpigmentation, you get patchy, irregular pattern of accentuation of the pseudo-reticular pattern or reticuloglobullar pattern on the face of pigmentation, along with a bit of erythema associated with these, because this is post-inflammatory, so a bit of erythema is part of it. There's also accentuation. Sometimes the pigment may be deep, giving a little bit bluish appearance. And post-acne pigmentation additionally has these scars, closed comedones, microcomedones, and even excoriations, micro excoriations. Pigmented contact dermatitis is actually just post-inflammatory pigmentation following spongiortic dermatitis, and it can occur most commonly following hair dye allergy, but it can occur in women particularly due to cosmetics. So there you have this fine brown granular pigment around accentuating the reticuloglobular pattern in irregular fashion, and associated with blotches of erythema. You can see ill-defined erythema in the background over here, and variable pigmentation depth as well as size. You can see the various size of globules of pigment forming here due to coalescence of granules, and even the color now varies according to the depth. Fixed drug eruption is another peculiar form of pigmentation on the face around the orifices, especially the mouth, nose, eye. It tends to occur around them. And this is the clinical picture. We are very familiar with the clinical picture. This is histopathology. Also, we are familiar. In histopathology, when it is biopsy, most of the times the acute inflammatory infiltrate and interface may be missing, because we are looking at pigmentation. So you may find clusters of melanophages as against scattered melanophages like this, which you see in lichen planus pigmentosus. But clusters of melanophages deeper in the dermis is typical of fixed drug eruption. And on dermoscopy, at the periphery of the patches especially, we find this bramble bush pattern, which I have pictured here in line diagram, but you can appreciate a bit of that over here as well. This is formed by the irregular curvilinear and branching pattern of pigmentation at the periphery of fixed eruption. That's a closer look at that, where you not just have the pigmentation but also areas of erythema in this. Nevus aorta very easy to diagnose clinically when it is typical, but sometimes when it is atypical, additional investigations may be appropriate. This is case of that, where you obviously see bluish pigmentation in speckled pattern on the cheek. Histopathology shows deeper down melanocytes which are pigmented, dermal melanocytes which are pigmented. So because it's one of the dermal melanocytosis, you have nuclei in this. In addition to pigment, in melanophages, nuclei are not visible, whereas in melanocytes, nuclei are visible. In nevus aorta, the dermoscopic pattern of brown and grey colored or bluish color, or sometimes even greenish tinge to the color of these macules is typical of nevus aorta, and that's what nevus aorta looks like. Look at the bluish background to this. This is atopic post-inflammatory hyperpigmentation. I call it post-inflammatory hyperpigmentation, but in fact you may not see any inflammation or no complaint of pruritus in such patients. You may see only pigmentation, which follows transient erythema in these patients. Around the eyes, around the mouth, these are the areas that are most commonly affected, and this is what patients come with, periocular pigmentation. You need to ask history of atopy in such patients, and on dermoscopy you can demonstrate not just telangiectasia and blotches of erythema, but also typical streaky pattern of pigmentation, which a streaky and curvilinear pattern of pigmentation around hair globules. So basically, it's a multi-component pigmentation of erythema, telangiectasia, and pigment globules. Seborrheic melanosis also resembles post-inflammatory pigmentation, but occurs in a particular pattern around in the paranasal fold, nasolabial fold, infralabial fold, also maybe around the eyebrows, sometimes on the cheeks, behind the ear, in front of the ear. So various patterns we do come across. So this looks like bilaterally symmetrical nasolabial fold affection, seborrheic melanosis. That's the histopathology, where you have the typical parafollicular parakeratosis in addition to spongiosis and other features. And this is the dermoscopy, where you have not just blotches of erythema, pigmentation of in granular brown pigmentation, which is accentuating the reticulogranular pattern on the face, but also micro scales and blotches of erythema, which indicate active inflammation in this condition. That's about the correlation of dermoscopy and histopathology, as well as clinical in diagnosis of facial pigmentation. I hope you have found this presentation helpful. I wish you a very good afternoon. Thank you.
Thank you very much for this virtual presentation, Dr. Vijay Kumar.
No.
Eminent how would you differentiate a psoriasis from seborrheic dermatitis with the help of dermoscopy? Because we of late there's the picture of psoriasis on the rise, not the typical psoriasis. So anybody could take up that question? Dermoscopy.
I think we are running out of time. So let's come to the second speaker.
I'm inviting the second speaker onto the dais, please.
background is not there.
I think the second speaker has left for his flight. And the last speaker of this session is Dr. Tulika Rai, who will speak on glycopeels in melasma. I'd request her to maintain the time because the next session people are there to go to airport. We will miss flight otherwise.
Good afternoon, everyone. I'll be quick. I'll be discussing about efficacy and safety of glycolic acid peels in melasma. So, melasma, as we know, is an acquired hyperpigmentation of the skin, and often it is resistant to the commonly used topical treatment, whether it's triple combination and sunscreen. So, we have to use a multi-modality approach to treat patients when they do not respond to the standard topical treatments. And chemical peeling constitutes an acceptable option in the management of melasma along with the topical treatment. So peel helps in improvement of the epidermal component. The dermal component is handled by the ability of the peel to induce the phagocytosis of the stagnant melanin. This is the pathogenesis that is explained. Deep chemical peeling for the dermal component of melasma is not recommended in patients of darker skin color, that is fixed fabric skin type 4 to 6. Since it can lead to scarring and severe PIH. Proper patient selection, good counseling, priming of skin and post-peel use of topical therapies is important to give a good outcome and to prevent post-inflammatory hyperpigmentation. So this is a very important step. Counseling is very important, and we should always give the patient a broad spectrum sunscreen with an SPF of 30 or more. And it should be started at the first consultation. So glycolic acid is a hydrophilic reagent. It works by decreasing the keratinocyte cohesion at low concentration and by epidermal lysis at higher concentration. The commonly used concentration is between 30 to 70%. 2 to 3 weeks apart, sessions can be given for a series of 4 to 6 sessions, and after that maintenance sessions can also be given. So many studies are available and they have shown good results with glycolic acid peels, and especially if you combine with topical therapies. And you can combine with in the priming you can give 10% glycolic acid in the initial 2 weeks, and then you can start with the peels. You can also use the modified clearance formula. You can use vitamin C, azelaic acid, and adapalene. So many studies are available. Now coming to the literature review, you can see that many studies are available. In the first study that was published in 1997, it was done on 10 Asian women. 20 to 70% glycolic acid peel was given every 3 weeks for a total of 8 sessions, and the priming was done with 10% glycolic acid cream and 2% hydroquinone. They found that there was improvement in the melasma and the fine wrinkling. In the second study, which was published in 2001 in Indian Journal of Dermatology, Venereology and Leprosy, 100 patients with melasma not responding to the conventional depigmenting agents were included. 55 to 75% glycolic acid peels was done in 68 patients, and 10 to 15% trichloroacetic acid peels was done every 15 days for 32 patients. And the response was assessed after 3 months follow-up period, and it was found that the response was rapid and better with TCA, but the side effects were also more with TCA. The third article was published in Indian Journal of Dermatology. They included 25 non-pregnant female patients with a minimum MASI score of 15, pre-peel sunscreen and 10% glycolic acid lotion at night was given for 2 weeks, 50% glycolic acid peel once per month was given for 3 months, and what they found that the p-value was significant. The epidermal type melasma had better response than the mixed type of melasma. So in another study, 10 female patients were included, and 1% retinoid peel was given on one side of the face, and 70% glycolic acid peel was done on the other side of the face at weekly intervals, and both peels were equally effective and well tolerated. So in another study, 21 Hispanic women with bilateral epidermal and mixed melasma, which was a split phase trial for 8 weeks, 4% hydroquinone cream versus 4% hydroquinone cream combined with 20 to 30% glycolic acid cream every 2 weeks, and along with the sunscreen with SPF 25 was given. No significant difference was found using combination therapy compared with hydroquinone alone. So even hydroquinone was effective, almost equally effective even when it was combined with glycolic acid peel. In another study, 10 patients were included. All patients were put on a maintenance regimen of retinoid, hydroquinone and mometasone furoate to be applied at night along with sunscreen. Serial glycolic acid peels were given at 3 weekly intervals, and the duration was increased after every peel. And it was seen that after 4 peels, 5 patients had greater than 50% improvement in the MASI score, 2 patients had greater than 75%, 3 patients showed fair improvement. Hyperpigmentation, irritation and persistent erythema was seen in 1 patient each. In another study which was published in Journal of Cutaneous and Aesthetic Surgery, the traditional glycolic, it was basically a review, and what they found, the traditional glycolic acid peels proved to be the best both in terms of safety as well as its efficacy. Level of evidence was 2:1 with strength of evidence 8. This was the US Preventive Services Task Force levels of evidence for grading clinical trials. In another study which was published in Indian Dermatology Online Journal on 30 patients, 50% TCA peel and 35% glycolic acid peel every 3 weeks for maximum 6 sessions was given, or if clearance of melasma, whichever was earlier. Priming was done with kojic acid 2% or tretinoin 0.2%, and it was seen that 70% participants in the glycolic acid group and 64% in the trichloroacetic acid group showed good or better response. There was no statistical difference between the two groups. However, TCA peel caused more discomfort and more adverse effects as compared to the glycolic acid peel. So in another 2 studies which were published recently, 112 patients of 18 to 40 years of age suffering from epidermal melasma, not taking any treatment for melasma for last 4 weeks were included. Total of 6 sessions of each peels with 4-week interval monthly. Post-treatment follow-up was done for 2 months. What they found was glycolic acid showed good efficacy and lactic acid also showed good efficacy. Efficacy was higher in lactic acid group, but it was not significantly different. In another study, which was published in 2019, 50 new diagnosed patients with melasma were included. 50% glycolic acid, 92% lactic acid was used in the 2 groups, which was given every 2 weeks up to 12 weeks. Priming was done with 2% hydroquinone cream 2 weeks before. Both peels have equal efficacy, but lactic acid peel is better tolerated. So there are many studies which actually show the efficacy of glycolic acid peel. Chemical peels are an adjunct to the medical therapy. They produce rapid therapeutic effects. They also improve the skin appearance and texture. With good technique, we can get good results even in dark skin patients. So we can go with the very superficial peels. And glycolic acid peels are well tolerated by most of the patients. We have to be very careful to give good pre-procedure care. Priming is important and post-procedure care should be advised to the patients. So I am sharing the clinical photos of few of my patients. In the first photograph, you can see that the patient has improved. Almost 50% improvement is there with 5 sessions of glycolic acid, 40% gel peel. In the second patient also we can see there is significant improvement. So there is actually a lot, even in our setup we are using glycolic acid peel and we are getting very good results. Thank you.
It was a wonderful talk by doctor. Youngsters, please don't forget glycolic acid peels are an equivalent to medical therapy, which she said that conclusion has to be taken as a take-home message. Don't start with peels right away and once the melasma patient comes. And always the mainstay is sunscreens, oral tranexamic acid along with your peels, and definitely glycolic peels are superior because we age, photoaging is common. We age with dyschromias, unlike Caucasians who age by eating clean. So it improves the collagen as well, and that also helps in melasma.
I think this session is over. All the chairperson and the speakers, please go to the corner, and Professor S.K. Singh will present them with the memento. Now we come to the next session, which is very important. That is immunodermatology.
I want to give basket of thanks to Dr. R.N. Datta sir for the given opportunity.
Thank you very much.
Same here, sir.
Dr. Sunil Ghate, Dr. Dinesh Ashati, Dr. Tulika Rai, please come to the podium. And the chairperson will be Dr. Dinesh Mathur.
Well, good afternoon, and without any this thing, let me invite Dr. Sunil Ghate. Dr. Sunil Ghate for Jack NIPS, this clinical evidence of off-label indication.
Thank you, sir. Thank you for the introduction. So I shall be speaking on tofacitinib off-label indications. This is the scope of my lecture. I will be talking about introduction, the JAK-STAT pathway, the pharmacology of tofacitinib, doses and monitoring, use in special populations, adverse effects, off-label uses in dermatology, the clinical cases and conclusions. So JAK inhibitors were developed and discovered and developed by NIH and Pfizer. It was FDA approved in 2012. Tofacitinib is the first FDA approved JAK inhibitor for treatment of autoimmune disease and was initially studied in anti-rejection agent in organ transplantation. It was initially called as casocitinib. Tofacitinib is FDA approved in the treatment of moderate to severe rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, polyarticular course juvenile idiopathic arthritis, and ankylosing spondylosis. So Janus is named after two-headed Roman god. JAKs exist as pairs, and kinase literally means an enzyme to move. There are 4 types of JAKs, like JAK1, JAK2, JAK3, and tyrosine kinase TYK2. And there are 7 STAT proteins, STAT1, STAT2, STAT3, STAT4, 5A, 5B, and STAT6. So I will not go into the detail about this. So there are multiple cytokines, more than 40 cytokines and growth factors which are collectively involved in signal transduction and which can be inhibited by the JAK inhibitors. So JAK1, JAK2, JAK3 and tyrosine kinase 2, they inhibit various cytokines as detailed in this particular slide. So tofacitinib inhibits JAK3 more than JAK1 and JAK2. It selectively inhibits JAK3, which is found in T lymphocytes, B lymphocytes, natural killer cells and the mast cells. It inhibits interferon gamma, IL-10 family and common gamma chain cytokines. Tofacitinib suppresses intracellular signal transduction of common receptors for IL-2, IL-4, IL-9, IL-15, IL-21, etc. So it's a small molecule with a molecular weight of 504 daltons. The peak plasma levels are achieved in about 0.5 to 1 hour. It is 74% bioavailable and the half-life is 3 hours and there is 40% protein binding. The metabolism is hepatic in 70% and 30% in renal excretion. It is mainly metabolized by CYP3A4 and there is less contribution by CYP2C19 like what we were discussing yesterday. So it is metabolized by CYP3A4. The inhibitors will increase the serum levels of tofacitinib, so co-administration at low levels is recommended. The inducers will reduce the serum levels of tofacitinib, the co-administration is not recommended. Immunosuppressive drugs like azathioprine, tacrolimus, cyclosporine, there is added risk of immunosuppression, and therefore the co-administration is not recommended. And in dosage is typically it is 5 mg twice a day. That is what we commonly prescribe in our patients. And the patients who are undergoing hemodialysis, the dose should be administered after the dialysis session on the dialysis days. Patients with lymphocyte count less than 500, you should discontinue the use. In pediatric, also nowadays the syrup is available, and the dose varies between 2 and 4 mg twice a day. In hepatic or renal impairment, the dose should be halved. That is, one should give half the dose of what we typically give, that is 5 mg twice a day. Here we should be giving 5 mg once a day. And patients with the absolute neutrophil count of less than 500 to 1000, we should interrupt the therapy till the count stabilize. And patients above 1000 cells per millimeter cube, till the time the cells stabilize about 1000 cells per millimeter cube. As I said, the drugs which are potent inhibitors of the CYP3A4 like ketoconazole and fluconazole, the dose should be 5 mg once a day. And patients with hemoglobin less than 8 grams, one should, or there is a drop in hemoglobin of more than 2 grams, one should interrupt the dose till the time hemoglobin value normalizes. There are baseline investigations are to be done like complete blood cell count, serum creatinine, liver function test, fasting lipid profile, HIV, hepatitis C, hepatitis B, serology, Mantoux test, quantiferon TB gold, and the XH test. And at 1 month post treatment and every 3 months thereafter, one should repeat CBC, serum creatinine, liver function test, and the fasting lipid profile. And for long-term use, annual screening for tuberculosis should be performed. And the guidelines for patients with for the risk of tuberculosis. So one should evaluate and test for active infection prior to starting the drug, and then one should screen the patients annually. And latent tuberculosis infection screening is done with quantiferon TB gold test, Mantoux test, and the XJ test. And patients who are confirmed to have active TB should not be treated with tofacitinib. Rather, they should be first treated with the multi-drug therapy for tuberculosis as per the nation's protocol, and then only they should be started on tofacitinib therapy. And in patients who have got latent tuberculosis infection, isoniazid therapy should be started, and patients should complete at least 1 month of isoniazid before tofacitinib is started, and the complete course will be 9 months. In view of the modest risk of transaminitis along with isoniazid, frequent monitoring of liver is necessary. And close monitoring for development and of signs and symptoms of tuberculosis is warranted even in patients who tested negative for latent TB infections prior to initiating the therapy. There are few adverse effects which we come across like upper respiratory infection, nasopharyngitis, elevated cholesterol levels, headache, upper respiratory infection, increased blood creatinine, phosphokinase, rash, diarrhea, herpes zoster, etc. And there are other adverse effects like hypersensitivity, GI perforation, lab abnormalities like lymphocytopenia, neutropenia, anemia, and raised transaminase levels as well as lipid abnormalities. Now, FDA came up with the black box warning in 2021. It is about active tuberculosis, invasive fungal infections, and major cardiovascular adverse effects. They have also classified this thrombosis risk also as a black box warning. And there is also a risk of malignancy and lymphoproliferative diseases as like other immunosuppressive agents. But this particular paper, they have ruled out the risk of thromboembolism only because of tofacitinib. In special population like pregnancy and lactation, one should avoid use. Geriatric age, one can use it below 65, but above 65, the risk of adverse effect increases. And in males and females with reproductive potential, the use of contraception is recommended, and they have seen reduced fertility in animal studies. In pediatric age, it is approved for 2 years in juvenile arthritis. And in hepatic and renal impairment, we should reduce the dose. In diabetics and immunocompromised status, watch for high risk of infections. And there is this whole list of off-label indications where we can use tofacitinib. I shall be showing some of the cases of mine. I'm not going to go into the details. This is my patient of psoriasis. This was unstable psoriasis. She had received quite a lot of treatment with all the conventional agents, and she was failing. And this particular patient had started on tofacitinib 5 milligram twice a day, and see the improvement in about 3.5 months. The psoriasis has healed completely with post-inflammatory hypopigmentation. This is a long-term follow-up. Post-inflammatory hypopigmentation is what you see. The dose was 5 milligram twice a day. So complete healing. I mean, when we are giving biology, we'll call this as PASI 100 response. Alopecia areata, I'm not going to go into the details about. I'll just show you the pictures. This was my patient of alopecia areata. Now this patient had alopecia universalis, and with other agents she had received partial regrowth, and whom I had started on tofacitinib 5 milligram twice a day. And this is the response, early response, quite a good response, and this will be maintained for sure. Now this particular patient has alopecia areata for years together. This is about 10 years history of alopecia universalis, and she is quite well on tofacitinib 5 milligram twice a day. In atopic dermatitis, this was a patient, again, she was failing other agents. Cyclosporine was given, it was giving improvement only for time being, and the disease was coming back. So was with methotrexate, and this girl was put on tofacitinib 5 milligram twice a day. And this is the baseline pictures, and this is the picture after treatment. After treatment, good improvement. I mean, near complete healing of atopic dermatitis with tofacitinib 5 milligram twice a day, and we can give it long term like other agents like cyclosporine. In vitiligo, I'll show you another patient of mine. This is a case of vitiligo vulgaris. This is a long duration. She had already received other agents. This is the baseline pictures. Tofacitinib was started. There is not much improvement initially. Late follow-up after about 1 year, and you see quite a good improvement at 1 year of follow-up. And then you see further. This is at the end of 2 years. The tofacitinib was continued for 2 years, and you see the improvement, near complete healing and near complete repigmentation. And this is the latest pictures. What you see that almost complete repigmentation has happened with tofacitinib, but now here the drug has been given for a long duration of 3 years. In 3 years, vitiligo vulgaris almost complete repigmentation. So this is before and after at the end of 3 years, before and after here. Other patches have also showed good improvement. This was a patient of atopic dermatitis. This was a patient of lichen planus whom I had given tofacitinib, and there was complete healing at the end of 3 months of treatment. This was a patient of granuloma annulans. This lady was coming to me for about 3 years, and every time she will respond only to steroids. Other agents were failing. And in this particular patient, look at the involvement on the abdomen also. And here I gave tofacitinib. This is the baseline picture. And this is at the end of 5 months. It's completely healed with tofacitinib, and which has been maintained. Another patient, this is about bullous pemphigoid. We were talking about it yesterday also. I have about 3 cases right now who are taking tofacitinib, and it is completely under control with tofacitinib alone. So this is the baseline picture at the end of 3 months. And talking about JAK inhibitors versus biologics. Now, while biologics typically target one single agent cytokine, JAK inhibitors can inhibit multiple cytokines at the same time. There may be unreported potential of generating neutralizing antibodies. The ease of administration and the topical route is what we will prefer JAK inhibitors, as well as the cost compared to the biologics. How safe are they? I mean, it's little early for us. About 3 years in the time we have been using JAK inhibitors. Coming to the conclusion, discovery of JAK-STAT pathway and its various cytokine interactions had led to unfolding and understanding of pathogenesis of many inflammatory conditions. Outpour of numerous clinical studies being conducted gives an idea that molecules will have evolution to the finest. Even the advantage of doses convenience and cost-benefit ratio, they do stand to score over the biologics. However, non-selectivity of targets and lack of long-term safety data underscore their ease of use. Benefit to risk analysis and proper counseling and monitoring should be advocated. Thank you all for your patient hearing.
combine tofacitinib with narrowband UVB for faster results, sir, in vitiligo patients?
That can be done. Unfortunately, I don't have narrowband UVB in my center. See, what I have seen.
I use narrowband with the
Yes,
tofacitinib. It works.
even
This
I
works.
use, and it won't take 3 years, sir. Hardly in 3-4 months the response is so good, actually.
Okay, I mean, point to be noted. I don't have narrowband in my practice, so I don't use it.
It
But
works.
what I have seen, the areas which are photo exposed, they respond faster compared to the other areas.
In pemphigoid, you only gave tofacitinib or steroid?
That was bullous pemphigoid, not pemphigus. Bullous pemphigoid, only tofacitinib.
No systemic steroid?
No systemic steroid. Patient was failing on systemic steroid. As the steroids were being tapered, the disease was coming back. So here only tofacitinib, 5 mg twice a day.
And the remission was found in?
So the 3 months the patient has improved and the patient is continuing the drug.
How long do you expect to give?
I mean, after some time I will try and reduce it to 5 mg once a day. I mean, that is what you will do with all other immunosuppressors.
Okay.
Be it psoriasis or anywhere else.
Thank you, sir.
Thank you.
Is there a panel discussion also in this?
No, it's gone.
Finished.
Finish.
Thank you very much. Is the last session of the conference or what?
नहीं अभी बहुत है.
अभी है ना? Free lunch. Okay. So I got the pride of inviting you to the lunch.
Okay, thank you very much for the beautiful session. The chairperson and the speaker can go to the corner, and Professor Deeptara Pathak will give you the mementos. Now the lunch is ready. It's yet hot yet. You go there and you can come back around 2 o'clock or 1 hour, and the prize will be given during the valedictory after all the things are finished. अच्छा ठीक है चलो. At 1:45
Not you can catch the flight.
Yeah, you can catch the flight. So please go for lunch.